It's fabulous to be here because, as I was saying to some ladies earlier, that I feel as though coming back to this region is very much coming back to my alma mater, because I did a couple of my degrees within Oxford and used to work at the John Radcliffe with the military cohort there. And, oh, do I need that? Oh, okay, sorry. Oh gosh, I feel as though I should sing a song now. And so it's fabulous to be back. And my background is critical care, so I did an awful lot of work with the Thames Valley Critical Care Network whilst I was here doing training. So it's fabulous to be here. But I'll keep quickly to time because I know what I'm like when I start talking. So in essence, the purpose of being with you all today and sharing this is a little bit about what we were doing around the tables in essence. So hopefully we haven't eaten too many of the picnic sandwiches. But the work that I've been doing is really about setting the culture for quality improvement within the Defence Medical Services. So true military style, I'll just go through a few of the points that I want to go through. But to outline the academic department of military nursing in essence, and to explore the model that we've devised in taking quality improvement amongst our cadre of nurses, but also our allied health professionals as well, because they don't sit within an academic body as such, so we've kind of scooped them up under our umbrella as well. And then discuss the progress going forward with disseminating that quality improvement. So it wouldn't be a military presentation without a line diagram. But in essence, all you need to take away from this is the medical director is my brigadier, my one-star boss. And then within the department that we have, the medical directorate at Birmingham, we have all of our academic departments down here. And I won't go into any of the rest of the acronyms, etc. But in essence, the Academic Department of Military Nursing was established in 2013, so we're really very immature in our progression. So because of that, we've got some academic departments down here that have been ongoing for 100 years. So we had gains to make, but we wanted to make sure that from a credibility perspective, we set off running rather than limping along. So what I did with the first job that I had in post as a senior fellow was actually to do a capability review for the Academic Department of Military Mental Health. And that gave me a great opportunity to look at some work amongst our own personnel, but really look at the literature out there in the public domain. And maybe I'm showing my age, but going back to the Briggs report, so I looked at a 40-year window in essence. And as we've seen today, please don't think that I'm suggesting that there's not some great research going on there, because clearly today you've seen that already. But the literature going through that period was showing that nurses were lacking hierarchical support. 10 years after, still the reports in the literature that the evidence was woefully lacking, and that at the 40-year mark post the Briggs report, where really evidence-based practice was really pushed and progressed, we were still regarded as nurses being relative novices. And I didn't want to fall into that loop. I didn't really want to go down 40 years. No, I'm not going to be here in 40 years, but I didn't really want to have to learn those lessons all over again. So where did we want to start from? So looking at what our nurses were saying to me, what our allied health professionals were saying, and also from the literature, we came up with a model of where we start, which is what we were doing really around the table earlier. And I broke it down into 4 pillars. So looking at each of those individually, all personnel within my team, so I as a defence professor, I have a senior research fellow, and I have a lecturer. We all have a tri-service feel in the fact that I'm Royal Air Force, I have my senior lecturer as an Army colleague, and my lecturer is from the Royal Navy. So we have a nice tri-service feel. We all have academic underpinnings for having the credibility to go out and teach. And a couple of us are finishing off our masters as well. And once you get on that academic pathway, you never get off it. So be warned. We also provide academic support to the Defence Studies programmes. So we go in and we teach ourselves, which is why we needed those qualifications from the outset. And the biggest point was to access our nurses at an early stage of their learning. So going in their 3rd year, before they do their dissertations, and focusing them on the research priorities associated with defence so that we get something back and our patients get something back that's relevant to the context of the military at the moment. We provide academic supervision, goes without saying, to our higher degrees, and those higher degrees are also attuned to that strategic picture so that there's no repetition of effort. We organise and deliver biannual forums, very similar to what we're doing today, and we exchange ideas, we provide that networking, and it encourages and motivates others. And I feel particularly motivated after today, seeing some of that fabulous work and in the posters as well. So it drives you forward, because when our nurses are being asked to do a lot of work in their own time, then that becomes a barrier in itself. Our nurses, especially when I did my undergraduate degrees, you had to do that in your own time, and that's the culture we want to change. I visit units all around the country, overseas as well, which sounds very glamorous, but again, it's so that we have face-to-face contact, so that I'm not just an empty entity to some people, enabling people to have an idea, network around the table, and develop it from concept to an actual design programme. We deliver publication workshops, so we go to that next stage. It's from that idea and getting it out there in the public domain to disseminate the work. And then at opportunities like this, I then give them opportunities to do conference presentations to prepare their work so that they can feel confident to go out and speak publicly as well, because that's another thing that puts people off, having that confidence to speak publicly. Collaboration, huge, perfectly exampled today. So what I did find was that internally, we as nurses, brand new academic department, were seen very much by our multidisciplinary academic colleagues as perhaps we're fairly new at this, we need to build our own reputation. So I physically took the hands of my academic colleagues and showed them exactly, I need to say this in the right way, showed them what we have to offer, so to speak, but showed the benefits that nurses can give to their programmes from a multidisciplinary perspective. So each one of those academic departments now, we have collaborative programmes with them, and they come to us, they bring their ideas to us now. So that pivot has already tipped. We do national work with a few universities, but that's building all of the time, and then international as well. So again, we're only 3 years in, and again, military presentation, what would it be like without a map? We always have those. But already we're showing our footprint on the global stage as well. I've spent an awful lot of time recently, as you can probably hear from the voice, out in overseas country and working with developing programmes as well. And we've already seen the work from development that you guys are already doing. So there's an awful lot of symmetry in the work that we're doing. I find the international piece particularly motivating because at the end of the day our patients are all the same, they have all the same needs, and if we work together we can save so much repetition. So coordinating all of that work, what we were doing was there were pockets of excellence that we weren't drawing together. So what we've also now done is built job plans. Doctors, I know there's a doctor in the room, are very familiar with this concept, that part of their job, they're entitled, they're legitimised to go forward and do work in the research field. Nurses didn't have that, so we're building within our military job plans 50-50 split. It legitimises the activity, gets them away from feeling guilty about taking a step back from care delivery and doing the quality improvement piece. So they are now enabled to do that. High degree projects are scrutinised by me and ensuring, as I say, that they're under that research strategy umbrella, so we don't have, we have the best use of the resource of the money that we spend. And then we oversee those projects, as I've already said. And finally, communication, hugely important. What we were finding was that we were, again, just thinking about the academic piece. So we have our subject matter experts, our specialist nurses, that saw that research was just the academic, just their role. Well, now we've brought them in to do some of the work themselves. So they then go off amongst their cadres and encourage the activity that we're talking about. So it's like a ripple effect, and that's really motivating them. And then Twitter was invented, apparently. I don't have a social media account, so it's all very new to me, but we do have an account and we do use it, or shall I say, I get somebody else to press the buttons that knows what they're doing. But that has already paid dividend. So our workshop numbers have increased, and our publications have increased, and that request for academic support is increasing. So it is working, and the outcome of that was that last December we had our first nursing journal piece with 10 authors within there that had never previously published. So we are getting there. So as far as research priorities are concerned, I just want to make sure that I'm not overrunning. I haven't heard the bell yet. So from an academic department, these are the areas that we're looking at. Preparedness for operations is hugely important. So we've just done a study on that. Looking at resilience. Resilience is a huge interest to me. Caring for the carers. I've done an awful lot of work on the psychological impact of what we ask of our personnel and what we ask of our nurses, our allied health professionals. And actually, if we can't be resilient ourselves, then how on earth can we be expected to deliver high quality care to our patients? So I took a stand in that yes, quality improvement for patients is huge, hugely important, but actually so are the staff, so are you, so are the people that deliver this care. So it legitimises again the acknowledgement that the organisation that you work for really cares about you. And that in itself, that message, that has already started to have an impact on people coming forward to get involved with the organisation and want to do the best they can for other people. And it's that little message that makes a huge, huge difference. Gosh, I've ruined it all together now, I'm pressing the wrong buttons everywhere. Charlie Thompson Edgar is a married name. Is going to speak to you shortly because I've heard her, but her involvement in the medical emergency response teams, again motivating, and I've focused on all of that work on her and her teams. And finally, our advancing nurse practitioner role, with Charlie being a perfect example of that. So we're looking at what skills are required, how our practitioners retain those skills, and innovative ways of managing that from an immersive simulation environment. We've just got a proof of concept of something for the medical emergency response teams that actually works. And I haven't got time to talk about it now, but it's phenomenally interesting. So again, really interested to get networking with people that have interest in the training field. And another PhD study is looking at ethics and the phronesis aspect of that, how we get our practical wisdom and being able to deliver that critical decision making to our patients. So all exciting stuff. So I put that up there to see if there's any ripple of interest of these areas within the audience. I think in a bell, so I think I must have done okay for time. So happy to answer any questions if there are any.
Hi there. Thanks very much for that. I'm just wondering where you see advanced practice going in relation to the armed forces, because obviously we had Charlie on TCP programme, and others are starting to do advanced history taking and things of that nature. I just wonder where you saw that going.
Thank you. We're doing an awful lot of work on that very piece. At the moment, nurses, as I was saying to somebody earlier, from the medical emergency response team perspective, we did an awful lot of our learning on the job, if you like, because we didn't know what we were going to expect. We didn't know what the trauma that our patients were receiving were going to appear like. So as far as planning and skill sets, it was an evolving programme. And what we learned over those times, and as you've seen in the reports in the media, that we were very good at what we were doing. And what we had to then do was retain those skills in the civilian sector. That's where we were struggling. So we're doing an awful lot of work. One of the PhD studies at the moment is to look at skill retention, how the universities and the clinical domains are facilitating that, and how long that skill retention occurs before skill fade. So it's something that we're investing an awful lot of money in at the moment to understand where best to do our training. But as I already alluded to as well, the experience of our personnel has been built within the training modalities, so immersive training. Huge piece, incredibly important for us, because as time goes on, we are proving that the nurse has a huge role within that operational piece, and that a recent study has shown that we've probably already got the skills required to let the doctor, in some instances, step down. And it's just proving that. And I think we're now at the point where we have just shown that there are certain moderately injured scores that we could probably be very capable of delivering a nurse-led service. That's not out there yet, but I think we're in that kind of domain. So,
any other questions? No? Thank you very, very much, Di. Absolutely brilliant.